Good evening, everyone, and welcome once again. My name is Dr. Marie-Claire Wangari. I will be your moderator for this evening's World Diabetes Day webinar on guidelines and recommendations for the treatment of type 2 diabetes. The theme of this year's World Diabetes Day is breaking barriers and bridging gaps. And with us, we have two presenters who will be taking us through this topic of diabetes. As we said, we will start at 7:05, so I'll just use this remaining minute to introduce our first presenter, who is none other than Dr. Paul Ngugi, who is a consultant endocrinologist with the Nairobi Hospital and formerly the head of medicine at Kenyatta National Hospital, a former member of the Kenya Diabetes Study Group and DMI. So without further ado, welcome Dr. Ngugi to give us your first presentation on guidelines and recommendations for the treatment of type 2 diabetes. We are happy to have you here and welcome to this World Diabetes Day webinar.
Thanks, Dr. Marie. And welcome to all the listeners and all the doctors on this webinar. Today is World Diabetes Day. It's great to have cap it up with discussion on guidelines and recommendations for the treatment of type 2 diabetes. Next. No conflict of interest. Next. Type 2 diabetes is a complex multifactorial metabolic disease whose risk factors are mainly chronic overconsumption of unhealthy calories, which is very prevalent in these days, sedentary lifestyle, which is a problem with the motorization of transport, and of course, genetic predisposition, and most times it follows family. And most of the diabetic people in the world are actually type 2 diabetes, and it's rising all over the world. More so in the so-called middle class economies, whose the joy of having more money and more food is becoming a danger to them. And most times it's poorly managed and is a devastating progressive disease. Next, please. It is associated with high morbidity and a reduced longevity due to macro and microvascular complications. We may not be able to discuss these complications tonight because diabetes is a big subject, but it's worse when younger people get diabetes. And we have known recently that we are getting more teenagers, the younger adults getting type 2 diabetes. And this disease is more severe than what you get in the elderly people. As diabetes is not only a health problem, but also a social and economic problem. Because again, you realize that most of the complications occur at the prime age of most of our clients. And current management uses multiple drug treatments. And all these drugs are many, and however, life expectancy is still reduced. And we will discuss as we go on whether there are drugs that influence positively on life expectancy. Next. This is a map showing the current spread of diabetes. But you look at Southeast Asia, Western Pacific, and us, because as the economy grows, diabetes incidence will grow. And currently, we are over 500 million people living with diabetes, most of them in the Asian countries, and are significant in the North America and the Caribbean. Next slide, please. Next. What is the pathophysiology of diabetes? Again, we can't deal with pathophysiology of diabetes in the time set. Suffice it to say, in simple terms, is an insulin resistance and beta cell dysfunction, two major pathophysiological factors driving type 2 diabetes. The insulin resistance is commonly in the muscle and is the earliest detectable abnormality of type 2 diabetes. Insulin alone does not lead to diabetes. Changes in insulin secretion determine both the onset of hyperglycemia and the progression towards insulin therapy. Next, please. What has recently come into be more in the vogue is the role of fat cells, or fat, especially fatty liver, and also fat in the pancreatic cell, in the zone of the pancreas. The fatty liver contributes a lot to insulin resistance, and the fat in the pancreas diminishes production of insulin. However, there are other pathophysiological pathways that have been established lately, and it's reflected on the change on treatment. Increased hepatic glucose production from the liver has been thought to be a major contributor to diabetes. And then the decreased incretin effect, especially in the gut and the pancreas. And lately, or in the recent past, we have established that there is increased the absorption of glucose by kidneys, those people who are going to get type 2 diabetes. Hence, with this slide, you can see the need for the new medication that are in vogue currently, and we'll discuss them as we go on. Next slide, please. This is a slide again that is showing the intersection or the confluence of chronic excess fat and accumulation in the liver and the pancreas. This is the central both in insulin resistant and beta cell secretory defect. Perhaps the participants may have heard of the journey the fatty liver has taken, and now is a very major treatment target for people who have diabetes and people who have insulin resistance and people who have impaired glucose tolerance. And it's important then, every time you diagnose a patient, you must always assess for fatty liver and treat it appropriately. Next slide. So despite advances in the understanding of which we have pathophysiology of type 2 diabetes and development of new strategies, current management is still suboptimal. And hence treatment with one single drug limits targets and doses and do not provide adequate glycemic control. This, you may have realized, the older doctors in the audience may have realized in the old days, we used to treat with one drug, wait for it to fail, and then we give another one. So the so-called treatment failure. And we think that is an old method and a method that does not achieve the objectives of limiting the complications and limiting cardiovascular incidences. So consequently, we'll discuss this issue a little bit more, the issue of combination treatment from the word go. Next slide, please. Next. How do we manage diabetes? What guides us? First of all, it's important, and perhaps I think we assume that we know what we're supposed to have our target. The normal target for especially HbA1c should be below 7, and hopefully maintain a target of 6 to 6.5%. But all patients must be, assessed individually. But that I mean is that not all patients we're going to want to achieve a 6.5 because of many hindrances. For example, patients who have lost short life expectancy, who have chronic diseases, malignancies, we may want to be less aggressive and aim to make them symptom-free. The other group of patients who don't want to achieve that aggressive target is patients who have experienced severe hypo. Do not forget that hypo itself is a cause of mortality and morbidity and has been known to cause sudden death in patients. So anybody who has had recurrent hypos, you should avoid aggressive treatment that may lead to hypos. Patients who have advanced micro and macrovascular diseases. Here I have in mind patients with chronic renal disease who are not at transplant, who are on dialysis, who again can have serious issues if you are very aggressive. Extensive comorbid diseases, and if those who have read their court trials must have seen that the aggressive treatment causes morbidity and mortality, especially patients with cardiovascular diseases. However, there's another group that you must be as aggressive as you possibly can. Those patients who have recently been diagnosed, it is what Kenyans say, mapema is best. You want to treat aggressively as early as possible so that you spare beta cells and you are able to get good outcome. Patients, again, who have long life expectancy, and these are the young patients that I mentioned earlier on, the early adulthood who are getting type 2 diabetes. You must not hesitate in introducing other drugs to improve control. And again, patients who have low risk of hypos, you can treat aggressively. And any patients who have no significant cardiovascular disease. Again, this last bit tells us that you must always assess your cardiovascular status of your patient as you move on. I mean, maybe every annually or after 2 years if there's not much problem, but always assess your patient cardiovascular disease status. Next slide, please. Next. With this in mind, I think we know that we have had very many new drugs that has come up. Among them is a glucagon-like peptide receptor agonist and the sodium glucose transporter 2 inhibitors. These two groups of drugs have demonstrated benefits for high-risk individuals with atherosclerotic cardiovascular disease, patients with heart failure. If you remember, there was the empagliflozin study and the dapagliflozin study. All these studies have shown good results and good life outcomes when started in these patients. And these benefits are largely independent of their glucose-lowering effects. Hence, the cardiologists have almost stolen the diabetologists' drugs and they have taken as theirs. But we are not complaining since we are serving the same patients. And these patients are initially introduced at glucose-lowering agents, but are now also suppressed. So we do prescribe these organ protection drugs in patients and perhaps as early as possible. And I emphasize here that there are times that you want to start these drugs from the very beginning. Next slide. So what are the fundamental aspects of diabetes care? These, I think, is every physician who is listening must practice or these both categories of aspects of care. Among the most important one is promoting health behavior in these patients, which includes nutritional therapy, physical activity, psychological support, weight management, tobacco, substance abuse, and counseling, sleep, and sitting. Now, this sometimes when you're busy, we may not be able to do this, but we like to encourage physicians who are looking after diabetes, at least to have some knowledge if they don't have nutrition there, supporting their centers to themselves have some fundamental of medical nutrition therapy, and also to understand physical activity that this patient needs to do, both aerobic and resistant activities. And again, there are situations when patients get very distraught, one at diagnosis, and they get into denial mode, and they get into looking for other practitioners who do not treat diabetes, but use other juju method or herbs that are not qualified or quantified. Smoking is a no-no in type 2 diabetes. Abuse of alcohol should also be, patients should be counseled and stopping. Of course, healthy living, sleeping, and sitting, but mostly sleeping is important, but sitting should be perhaps discouraged as much. You don't sit too much. Then for the doctors, then you'll educate the patient, of course, behavioral interventions, pharmacological interventions. And currently there are devices that are used, one, for glucose monitoring, the CGMP, the continuous glucose monitoring gadgets that are available. Metabolic surgery has been practiced, has been used, and has had benefits. Bariatric surgery has been used. And, but as we move on to the new drugs, you are finding some drugs of equal results or as good results as bariatric surgery. So targets not only AIC but also weight. So you look at your patient and give them targets. So again, when you see them, when you're discussing care with your patients, you discuss targets. So you discuss HbA1c as a target, and you discuss with them weight as a target, and then your journey will be to achieve those targets. Next slide. Next slide. So this treatment will require multifactorial behavioral, as I said, pharmacological treatment. The goals of therapy is to prevent or delay complications and maintain quality of life. It is not an intention of a diabetologist or a physician to make the life of our patient miserable. Is to find that there is quality by achieving good control. So glucose levels are important, and then you must deal with cardiovascular risk factors like blood pressure, lipids, and smoking. Deal with comorbidities and complications and treat them as they come. Next slide. Now, what's new in the consensus? This is a bit old because we've had two consensus reports last year and 2024, but there isn't much change from this consensus statement, even the current one, maybe the newer drugs. But weight management aspect has become more emphasized now, and we want patients to achieve 10%, 15% body weight. And it's now possible based on the direct study. Weight loss of 5 to 10% confers metabolic improvement. This is the weight reduction that you want to do when you are talking about low calorie diet. Some people are using intermittent fasting, keto diet, very low calorie diet to achieve this. And then there are drugs that we have seen now that are in the market that help you achieve this. So weight loss has a benefit that extend, and this it extends beyond glycemic management and improves risk factors like cardiovascular disease and quality of life. Next slide. We can move on. This is showing that the improvement in HbA1c at 12 and 12. Can you go to the next slide, please? So again, when you're looking at the patients, we must have a holistic patient-centered care. So you focus on your patient. If this patient you want to protect cardiorenal protection, because again, what kills our patients is cardiovascular diseases, and what kills even the renal patient when they get kidney problem, most of them die from cardiovascular disease. So cardiovascular risk factor management and weight management is very critical in management of diabetes. Of course, blood glucose management is important, as has been shown by many studies like UKPDS and DCCT that show that when you optimize blood glucose monitoring, you also improve cardiovascular disease. All these elements are of equal importance, and not one is better than the other, so they must be done together. The other issue is therapeutic inertia, which people associate therapeutic inertia with insulin commencement. But I've found even in oral hypoglycemic agents, you find patients are resistant, and some of them want to stop immediately their sugars gets normal. And even if you don't allow them to stop, some of them will stop anyhow, and later on come back with bad complications. The liver complications must be assessed. I said earlier on that you must scan the liver and do liver function tests. And if you have fatty liver, then you must treat. And more so, be watchful of liver function tests that have high ALT and AST, because those ones are now at risk of liver hardening. Now, other than the ultrasound, especially those patients of high ALT and AST, you want to do something called a fibroscan that will guide you whether the liver is hardening or is moving to cirrhosis. And of course, when you come from cirrhosis, you end up getting to adenocarcinoma. So it's important that liver is assessed. Next slide, please. Next. Next slide. Again, this is showing the patient that is at the center of everything we do, putting the person with diabetes at the center of care. Next slide. What are the key person characteristics that you must take into consideration? Individual priorities. This is where we say you negotiate with your patient. You find out what are their issues so that you try and fit into them. Sometimes when doctors try and impose themselves to patients, patients assist and they do not cooperate. Look at the current lifestyle, occupation. Is it somebody who works night duty? Is it somebody who is a truck driver? Is it somebody who works heavy machinery? And then you look at aspects of age, weight, and then psychological issues such as motivation. If you're going to start somebody on insulin, you must first of all get them motivated enough to want. Perhaps the journey will be to make the patient motivated in the care. They become equal partners with you, so that it's not the doctor imposing issues. So the patient can come and tell you, Daktari, my sugars are misbehaving the last 1 week. That's a motivated patient. There'll be another person who have perhaps depression, who doesn't want another added tablet, and they break down in your office crying. And then shows you determinants of health. It shows you environment. There is this issue, we want to start somebody on insulin, and is an elderly person. You have to find out when the relatives are in the house to come and inject them. Also, don't forget that some people, improvement or change of treatment sort of make them change their career or lose jobs. For example, using insulin perhaps will not go well with people who are driving PSV vehicles because of the risk of hypoglycemia. So I'll mention this, and then again the issue of education levels, because again that tells you what you can discuss with the patient, what literature you can give the patient. Because some patients can be able to read up their stuff and be able to discuss it with you properly. Societal and political ideologies and policies that may come with support in terms of like financing healthcare, both inpatient and outpatient. I don't know politics, perhaps I don't know how to get involved, but politics is what drives everything. So it's important. There are other people who have things against maybe current medicine. They would like to, their spiritual religion is very important in terms of how you navigate people who have beliefs that are not in keeping with good diabetes care. Next slide, please. So, and this again is a repetition that individualized glycemic and weight goals. Discuss with your patient what are the glycemic goals. And here I think what's important, you want to tell your patients, discuss the fasting sugars. Many times patients only test fasting sugars and they don't test postprandial sugars. So you must discuss that they must test both fasting and postprandial sugars, because most of the time is a postprandial. Discuss about weight and hypoglycemia. And here you want to really tell them, inform them about the hypoglycemia symptomatology, treatment, and then the issue of goals, the reason for these goals. Please spend some time in telling them about side effects of medication. Metformin, for instance, patients who have diarrhea and they don't know why they're diarrheaing, and then they'll go to physicians who don't know about the side effects, and then there will be a lot of H. pylori treatment, and again, some patients will be admitted in hospitals with electrolyte imbalances because they diarrheaed for a long time without treatment. Then choose a treatment that patients can adhere to. Here I have, especially insulin. Sometimes the base of bolus insulin is very challenging to elderly patients or patients who have irregular meal patterns. And sometimes they may have just do basal insulin, combined with OHs. And again, assess cost and availability of medication. Currently, there are drugs in the Kenyan market that are costing over 100,000 Kenya shillings. Perhaps those are drugs that you may not want to discuss with everybody, but then there are some patients who can afford it. So discuss these patients and inform them of what is best and what's available and what's best for their situation. Next slide. Next slide. This is a very important slide because the patient sees the doctor only once, maybe in 3 months. But most of the time, if you're going to succeed, your patients must know how to manage their diabetes, must know. And this involves a lot of education. And it's important wherever one is to maybe improving himself, involving himself in maybe workshops for patients, making them understand to demand or to do HbA1c, making them understand most times about complications and how to get assessment. Sometimes you find patients has had diabetes for 20 years and has never had an ophthalmological assessment. And not because he didn't want to, but because he did not know. How often do you do renal assessment in these patients? How often do you perhaps assess their psychological outcomes? Do you look for the depression in these patients and perhaps seek psychiatric help? And then cost effectiveness, a drug must be affordable and must be effective. And what is affordable for one person may perhaps not be affordable to the other person. So if you look at your cohorts, there are patients who will take blooded drugs. They don't want generics. The other generics in the market that are pretty good and will give nearly as good results, and that may benefit other patients. So do not restrict yourself to one group of drugs for all. Look for drugs that other most of your patient can afford, or different groups of patients can afford. So potentially reduce the risk of all cause mortality. Next slide. Next slide. So before I forget the other slide, is that I have seen in some countries that patients themselves form in groups, and doctors encourage that. And they form groups for those patients where they will be having some time, maybe like World Diabetes Day, you go and talk to them, or any other day you have a camp for them and they come and ask you questions, and they also interact with other patients. This gives each other strength and understands that they are not alone in this journey, and consequently they are motivated to do better. So you want to discuss again this thing. Next slide. Next slide, please. This is a exercise that one may want to do the whole day. There'll be sleeping time, there'll be exercise where you have to sweat. And these are discussions you usually have with patients. Patients tell me, Dr. me, I work from 8 to 5 p.m. I'm moving up and down, but they do not achieve what the exercise is supposed to achieve. Sweating is very important. It improves insulin resistance. And when you're sitting down, like busy doctors or lawyers or accountants, they must wake up and move. Of course, there's strengthening muscles are very important. And most important, sleep, even to the very busy one, sleep helps you rejuvenate. So improve all this, educate your patient on all these aspects of healthy living. And believe me or not, sometimes you think they know it all, but they don't. Next slide, please. Just a brief view of these drugs. I'm not going to discuss much about them. Metformin is a drug that all of us use. It's common. It has minimal hypoglycemia risk and is potential for some modest weight loss. The only thing I would like to mention about this drug here is that traditionally we have been using metformin after food, but studies done lately, especially published in the last 3 years, has shown it should be used before food. It's a drug that is still not known, not much is known about it, but for when to use it, we know now it's best used before food, not after food. And commonest side effect for this drug is diarrhea and abdominal problems, I mentioned. There has been talk about vitamin B12 used in combination of this drug, but again, I think people have to be at risk of having vitamin B12 deficiency for it to be significant. And it's reasonably cheap. Next slide, please. Next slide. These are sulfonylureas, drugs that most of us grew up with, used them, and there are many types. Again, I would like to mention that they are cheap, they work well, but they have one drawback or two drawbacks. One is hypoglycemia, and the other one is weight gain. I must also say that in the study that is called UKPDS, it was shown not to be dangerous. But as a practice point, that you must be very careful. When I was training, we used to be taught you start with 1 tablet, increase to 2 tablets, increase to 4 tablets. All this time we are increasing these dosages, the HbA1c is going and the complications are coming. My practice issue is that if you start a sulfonylurea with something and you are 1 tablet or half a tablet and your HbA1c is not getting better, adding another tablet does not change very much. So it's pointless adding a glibenclamide from 1 tablet in the morning to 1 twice a day. It will not achieve a significant HbA1c drop. So if they do not succeed, add another drug that works differently. Do not keep on adding as you're having 4 tablets of sulfonylurea. Next slide, please. These drugs, again, they are drugs that we were very excited about. Unfortunately, losiglitazone, which was one of them, had problems of mortality and morbidity and was withdrawn. Currently, we have only one drug called pioglitazone. This drug have side effects of edema and weight gain. But for this drug, pioglitazone is the only drug that has been studied that has shown benefits in stroke. So again, you make your choice whether you want to use it despite those side effects. It has also been found to be very useful in fatty liver. So it's a drug that you can use for patients who are at risk of stroke, fatty liver. But if for any reason, although it has not been shown to have effect on heart failure, I think one would be advised to stop it if your patient has a risk of heart failure. Next slide. Next, the DPP-4 are newer drugs, and these are drugs that inhibit the enzyme, the DPP-4 enzyme that breaks the GLP, so that the GLP, which has a very short lifespan, lasts long in the system. They have been useful in terms of helping, but their effect on hyperglycemia is very modest. So it's a drug that you have to not depend on to bring HbA1c below 1%. The HbA1c excursion is about 0.5%. 0.5%. So currently, I think their use is in combination with other drugs. They have very low risk of hypoglycemia, and they are almost weight neutral. They come in various ranges of prices. So they're used perhaps, I find their use perhaps very useful in the elderly where you want not to be very aggressive and you do not want to get them to get hypoglycemia. Next slide. Next slide, please. Next. The SGLT2 drugs are also newer drugs, but these drugs are revolutionary. Basically, they inhibit the glucose exchange, the absorption. They decrease the glucose absorption in the distal tubules, and they have been known to be very useful. Their blood glucose control is not very bad. It's not like DPP-4, but most important is the effect on the heart. If you look at the empagliflozin studies, there was benefit in life, disease progression, and now even the kidneys, they're very useful. Previously, we were told not to use them in people with an eGFR of less than 45, but you find now people are going to eGFRs of 20 and below because they have shown benefit. I must add that once you start them in patients with decreased eGFR, there is initially there's a drop on eGFR, a small drop, and later on patients, that improves and is maintained. So all patients with heart disease or CKD must be on these drugs. Perhaps this is not the time or the place to discuss their mode of action, but there's been very many theories because these benefits are not glycemia related. Currently, in this market, we have two, empagliflozin and dapagliflozin. We used to have another one called canagliflozin that has been withdrawn or not in this market. The best of my knowledge. Next slide. Again, another group of drugs that has revolutionized treatment in terms of their glycemic control. They are very good. They have they help control sugar well. They also help in weight reduction, although the weight reduction is modest. The effect on heart failure is neutral, and in terms of kidney disease, there is benefit for renal endpoints driven by albuminuria outcomes, but it's not as good as the SGLT2. But if you look at, there is one, there semaglutide, which is a hot potato in the world, and even in this country, it is hit the country by a storm. This is a drug that has been found to cause reasonable gait pain and is good cardiovascular outcomes. But I think its effect on weight has ended up being a good thing and a bad thing that has opened illegal markets and people misusing it and people wanting it for beauty purposes. But they are important drugs. There are very many studies, the sustained studies that have been studying semaglutide. But it causes nausea and sometimes low appetite. And usually it's good you start them small dose, maybe 0.25, 0.5, then you go to 1 milligram. And it's available in both oral and subcutaneous injection. The oral tablet has not been in this market. Maybe it will come soon, and we will embrace it when it comes. There used to be another one called liraglutide that has been around for some time, and also it has some benefits in weight loss, but not as great as semaglutide. Next slide. Next slide, please. Now, tirzepatide is a very new drug, and this works in both GLP and GIP receptors. It's one of the most potent drugs in weight reduction. That's actually better than semaglutide, and also the sugar control is important. Now, I think we're still a long way to knowing where it will fit, but in the weight reduction, it's fitting very well. It's also very effective in glycemic control and doesn't cause hypoglycemia. The cost of these drugs, both tirzepatide and semaglutide, is prohibitive for most Kenyans. And even when you look at the generics, they are all in the tens of thousands. So for most people, so far, they're not very affordable, they're expensive. But I'm finding it useful to those people who want to lose weight. Next slide. Next. Then this is the old insulin. Of course, dear doctors, I think you all know the history of insulin from 1920s, how it came to be, the journey with zinc, protamine, insulin, animal insulin, and currently we having insulin that is human. Then we have the different modes of action. They have the uterus short-acting, and long-acting. And this has helped us to be able to manipulate or try and simulate physiology in terms of if you are aware of the first peak when you are eating food, the pancreas releases insulin, very fast peak, and then there is a slow peak, slow level that comes. That first peak is supposed to influence the postprandial sugars And that's why we used to have the ultra short acting. We have insulin aspart, insulin Rispro, and they're very useful. And then we have glargine and detamere as a basal insulin. Not insulin is very, because it does cause hypoglycemia, and it's one of its greatest risk. Otherwise, other than that, and the weight gain, it has very little side effect. It's very important to patients when they have HbA1c is quite high. It's the only drug that we know of that has, quote unquote, perhaps limitless capacity to lower the HbA1c. What I'm saying is that all these drugs I've discussed before, very few of them can reduce the HbA1c by more than 1%. Perhaps the GLP-1 and the GIP and GLP can go 1.5. But if somebody comes to the HbA1c of 10, these drugs are not going to work, and insulin has to be used. And it's also the drug that has the greatest inertia of start, so that patients do not want to start insulin. They will cry, they will tell you, let me come next week, and then they will disappear. They go and see Dr. X somewhere, will tell him, hey, Dr. anapenda insulin sana, let's try this additional drug. But nothing will you add to patients of that HbA1c above 10 that will change the HbA1c. So again, you have to try and work on that inertia, both doctor inertia and patient inertia, because doctors also have great inertia about starting insulin, but it truly works. Sometimes the challenge is that we have a patient whose sugar is badly controlled, he or she is overweight, and they cannot afford those are the drugs, and the sugar is badly controlled. And you ask yourself, what do you do? You start insulin the way it is going to get higher. Again, it's a combination of many things. You're going to have behavioral intervention, diet intervention, exercise intervention. And when you use insulin, perhaps involve the basal bolus, which has you use small dose of insulin and a small dose of also the basal insulin to try and mitigate against the weight gain that you may get with insulin. There has been some, one study that came up like 10 years ago that said one insulin was carcinogenic, but that has not proven with time. Next slide. Next slide. The combination therapy. When do you do combination therapy? I think it's important that in my own view, I think it's important that when you're treating these patients, you aim to attack or to deal with the multiple pathophysiological processes. And it doesn't matter when you're getting these patients. I think myself, the time for starting patients on one drug alone, rather than the pregnant mothers, I think is long gone. You must try as much as possible to look at a drug that helps weight loss, a drug that improves cardiovascular risk profile, and a drug that deals with the sugar. So you can have one drug that deals with all those, so be it. But if not, do combination therapy from the word go. Next slide, please. And especially to those patients with HbA1c of more than 85%, who we need 2 drugs to bring the patient to below 7. And then younger people with type 2 diabetes, people in their 30s, people in their 20s, and people in their 40s. And believe me, even people in their 50s are called younger people. So try and be aggressive from the word go. It is called hit hard in the beginning. In those whom stable, and do not perhaps consider stepwise approach, because that would, unless there is a good reason you're doing that. And cardiorenal protection, pick those drugs that have cardiorenal protection. Again, pick your patient wisely. I mean, there may be a patient who may not require cardiorenal protection, but it needs a glycemia to come down. So as you combine them, ask yourself, this patient, what do they need? from me or from the medicine, and then address it appropriately. Next slide, please. Next. I think we have gone through this, but I think it's important that you just see, you can choose between GLP-1 and then that's GLT2. And for those above targets, at one time you may have to use insulin. The role of TZDs, I find myself using it, especially to younger people, and especially those people with fatty liver, you may find it useful. Next slide. Next slide. Obesity is again another comorbidity that is important that you address. This is in combination with fatty liver. And also there is the obstructive sleep apnea that occurs with these patients. And again, you have to treat both of them. This obstructive sleep apnea, you want CPAP, you want position, you want urgent weight loss treatment. These are the patients who, in absence of the other drugs, the semaglutide and the tirzepatide, you may want to advise bariatric surgery, because when they lose weight, they'll be able to exercise, you'll be able to sleep well, the lungs, the pulmonary hypertension will come down. So it's important you treat them perhaps a little bit different from the others. Next slide. Next slide. We have discussed this before, but I think just to emphasize, an anachoric steatohepatitis has been known to be a complication that is serious, that affects life and causes mortality and morbidity, and must be treated very well. Of course, the fatty liver is a center of insulin resistance. So as you manage it, you're also managing diabetes. Next slide. Next. Next. This we have discussed that the stepwise approach that is practiced by some people leads to expose periods of uncontrolled HbA1c between treatment steps, and studies have shown that there is significant delay in introducing a second oral agent, and this is resisted by patients. So especially if the patient has been on one drug for a couple of years, to introduce another one becomes difficult. Patients who have had 2.9 years between initiation of the first OAD and the second, and 7 years before initiation of the basal insulin, only the 53% of patients in the USA, only 53% of patients in the USA are receiving stepwise therapy. Only 53% of patients in the USA achieving stepwise therapy achieved and maintained the target of HbA1c of 7%. So you can see, rarely will you achieve a good HbA1c if you are starting one drug, then adding another one, and the other one fails. So I think for this slide, I think is to categorically say, do not, especially patients who have serious issues of diabetes, do not do that stepwise. Start multiple drugs. And that's why there are combination pills with SGLT2, DPP4, or with metformin. I would find that we transit to that type of treatment, and our patients will do very well. Next slide, please. This is a UKPDS study that I've mentioned severally, that it's showed that if you tightly control your patients, you reduce all the three MACE, diabetes-related point, microvascular, and myocardial infarction. All of them went down. So it's important to treat diabetes aggressively because of those benefits. Next slide, please. Again, we have been emphasizing the need of combined treatment from the word go. And it's important that we do that from the very beginning, or do not delay combining. Let me give an example here, because I think you may have had a good spell with one of your patients with one drug. they may have had HbA1c 6.5, 7, then 7.1. Then you are reluctant to introduce another drug. Please be encouraged that that will be the right time to introduce another drug before you reach the 8 and the 9, so that you go back to the ideal HbA1c. Next slide. So again, we have talked about this severally. So oral combination that may be given a separate dispense individual medication or fixed combination. The fixed combination maybe have a challenge that you cannot influence the dose of one without influencing the dose of the other. But again, I think, like I said, changing the dose of one specific drug does not change the HbA1c much. So the only nice thing is to add another agent. Next slide. Then there's this study that was done on vildagliptin, which again, just to summarize this study, it showed that a combination of vildagliptin and metformin is much better than starting with metformin alone and adding vilda later. And this is the only study that's known that has been done well, randomized, double-blind, that showed that combination therapy works better than individual therapy. Next slide. Next. These are results from the Verify. Next. So in conclusion, Verify showed that early combination treatment with metformin and vildagliptin improved glycemic durability in patients with type 2 diabetes compared with the standard of care of initial metformin and adding vildagliptin. And early combination treatment significantly reduced the probability of initial treatment failure. The time to second treatment failure and the time to treatment failure compared with monotherapy through the 5-year study. Early combination therapy with metformin and vildagliptin is well tolerated and is safe to use. Next slide. And this, I think, goes for all combination therapies we are seeing, be it an SGLT2 and metformin and SGLT2 and DPP4. So they all, I think, personally, although individually I'm not studied, I think this can be replicated in all those combinations. So the summary of conclusion is that treatment of diabetes should be individualized. Treatment should consider pathophysiological mechanism and should be started early. Initial combination therapy based on addressing multiple pathophysiological abnormalities is feasible for some patients. Initial combination therapy with metformin and another agent offers the advantage of early achievements of glycemic goals than use of therapy. Next slide. An early intensification of treatment is important to prevent complication. So do not wait for HbA1c to go. In actual fact, the recommendation is an HbA1c of above 8 requires intensification to the extent that insulin would be recommended to most young patients if they get the HbA1c above 8. Treatment should focus only on durability and improving beta cell function. Durability, that means it's going to last long and improves beta cell function. And beta cell function improves anytime you go from high sugars to low sugars. You get even the reserve beta cells starting to produce insulin. Management should depend on the presence of heart disease, heart failure, DKD, irrespective of the HbA1c. If one of these comorbidities is present, then consider GLP-1, RA receptors, SGLT2 inhibitors. If no risk identified, proceed with the usual guidance of initial metformin plus another oral agent. Initial metformin plus another oral agent. Next slide, please. Next. Empathic personal-centered decision-making and support informed by an understanding of local resources and individual social determinants of health are important to improve. Basically, you're asking people to understand their patients, be empathic to them, look at their surrounding. There's no point of prescribing something nobody's going to afford. There's no need for telling somebody eat this, and you know they will not eat it because it's not available. And practice point that I have, that always understand the patient's social status, surrounding and local resources before you advise them. Consistent efforts to improve health behavior in nutrition, activity, sleep patterns, self-monitoring, and provide diabetes self-management education and support are essential to empower people living with diabetes. So we must empower our patients for them to be in charge of their diabetes journey. We as doctors, we are basically facilitators and advisors. The whole journey and the whole treatment of diabetes would succeed only if the patient is empowered. Next slide, please. Next. Next. Thank you very much for listening. That's about it.
Thank you so much, Dr. Ngugi, for that detailed presentation on management of type 2 diabetes. I would now like to welcome our second speaker to present, and then we will take the questions. We'll take a few questions before we close this, hopefully around 8:15. So our next speaker is Mr. Rinton Chakraborty, the head of marketing at Square Pharmaceuticals Kenya. You're most welcome to give us your presentation.
Good evening, Dr. Mary. Am I audible?
Yes.
Yes, you are.
Thank you. And the slides are visible?
Yes, they are.
Great. First of all, I would like to thank you, Dr. Paul Gugi, for the excellent presentation. We really appreciate, which was time demanded and elaborate. So I will not take much long time, maybe a few minutes, just to give a brief about Square Pharmaceuticals and what we are doing in Kenya, and what are the products we offering for the patients to manage their diabetes, especially the combination therapy. So Square Pharmaceuticals, the company from Bangladesh, and it is the first multinational company from our country, which is leading the pharmaceuticals market in Bangladesh. I want to give a brief about Bangladesh pharma market as well. If we see the figure, Bangladesh market is currently in pharmaceutical sector almost self-sufficient. We produce our product locally, and 99% product we already have in our country by our local manufacturing facilities. So if we see the figure, the situation was not like that. If we go back 30 years or 40 years back, in 1981, almost 75% products was being produced by multinational, and it was imported actually. And only 8% or 25% medicine was produced by local pharmaceuticals in that time in the country. With time, by development of our pharmaceutical sector in the country, at the same time support by our doctors community believing that local company can produce good quality medicine, we were able to take over the market, and currently 92% medicine are being produced by local manufacturer, and only 8% medicine are being produced by multinational, and this medicine are being produced inside the country actually. So that is the situation in Bangladesh pharma market, that we are now sufficient in producing medicine by ourselves. So we are sharing this concept because we want to implement the same things in Kenya. You will see my presentation in later slides. Square Pharmaceuticals started its operation as a small venture in 1958, and currently we are diversified in 27 sister companies apart from pharmaceuticals. We are in healthcare. We have natural products. We have hospital. We have also textile. You might know that Bangladesh is very good in textile, and Square is leading in the sector. In the overall Bangladesh, textile is either number 1 or number 2, always competing in the world. Big brands, Adidas, Puma are coming from Bangladesh, and Square is also leading in this textile sector. We are also present in fast-moving consumer goods. We have our toiletries company, snacks and spices. We are also IT sector. We are also in media entertainment, and as well as agro processing sector. So Square Pharmaceuticals, apart from pharmaceuticals, we are diversified in 27 sister companies. And in the group of Square, more than 65,000 people are working in different sectors. Currently, Square market capitalization is $2 billion in the stock market in our country. And globally, we are present 45 countries in the world, including US, including South America, including Africa, many countries, Kenya, Tanzania, Burundi, Mozambique, South Africa, Mauritius, and other countries. Oceanic countries, we have our presence. Asia, we have our big operation, including Malaysia, Maldives, Myanmar, other countries. Europe also, we have our operation. So you will find Square is operating currently 45 countries in the world to supply the medicine from the country. That's happened because of our very vast and robust manufacturing facilities. Currently in Bangladesh, we have 15 different manufacturing sites where we produce different products, including insulin, MDI, etc. Our many sites are approved by USFDA, UK MHRA, TGA Australia, SAHPRA South Africa, and BISA Brazil, and many other regulatory authorities. These are very, very stringent regulatory authorities who approved our plant, and now we are able to supply the medicine from our Bangladesh manufacturing plant to big countries like USA, UK, and other countries. This is some of our production facilities inside the country. I'll not go through the details because of the time. We have separate and dedicated penicillin unit, nasal medicine unit, general solid dosage pump 1, which is approved by USFDA and other regulatory authorities. This is cephalosporin unit dedicated. We have dedicated ophthalmic unit where we produce eye product. We have dedicated insulin unit also where we have both human and analog insulin. We have another general solid dosage unit 2, which is one of the biggest manufacturing site in our country, where we can produce 10 billion tablet and capsule per year. And also it has been constructed as per USFDA and EU guideline to qualify there. This is our latest Square Life Sciences, which has been started operation from last year first quarter. It has capacity of 6 billion tablet and capsule production per year. We have Center of Excellence Research Center, where we have number of scientists work for producing quality medicine at affordable cost, do the research, ensure the products are in good quality, good formulation with less side effect and affordable. Now the figure we have or the topics we discuss first about the local manufacturing facilities, the same concept we have come with in Kenya, that as Bangladesh economy is almost the Kenyan economy, so we should use a similar model so that Kenya can be also sufficient by producing pharmaceuticals product locally. And we have set up a big manufacturing plant in Kenya, which is actually the biggest in Eastern Central Africa. The plant is located in EPZ Athi River. We started this construction from 2018, and the plant is operational from last year. Products are already in the market. If you can see the land area, we have taken 17 acres and 6 plots in EPZ. We are planning to employ more than thousands of people in this plant, and the investment is $75 million. It is the technology transfer we are doing from Bangladesh, the same quality medicine, same technology, complying USFDA, TGA, UK MHRA, SAHPRA, and many other regulatory bodies compliant. So that is currently going on. Plant is now operational. This is the 3D model of the plant. We have 3 phases. First phase is this one actually, where we have the solid dosage pump. We are coming with liquid very soon, and injectables in our 3rd phase is also coming. There's a small
Retirement profile of Kenya's pharmaceutical and manufacturing sector is set for a major boost following the installation of a plant in Athi River Town, Machakos County. Now, Bangladesh-based company Square Pharmaceuticals has built the factory on 6 acres of land at the export processing zone in Athi River. The total cost of building the plant is estimated at 8.4 billion shillings. Now, the facility, which will start production early next year, is expected to help minimize the country's dependency on imported pharmaceuticals and reduce the cost of drugs. Kenya will also receive technology and training to manufacture difficult-to-make medicines such as anti-malarial, antipsychotic, anti-diabetic, and antiretroviral drugs.
I strongly feel that not only Kenya, but Africa cannot be dependent on the imported products for a long time. And we strongly feel that when we are going with GERDS, we are not looking at only at the Kenyan market. And there's also the agreement that we have with the Kenyan government that a large portion of our products also will be exported, and thereby we'll be able to cater the need of the Kenyan people and also to other countries also, and not only the other African countries, but even in other developing countries also.
That was during our groundbreaking about Score Pharmaceuticals was published in the newspaper. Now the plant is reality. We have this plant already in the ground. It's operational. This is some picture of the plant. This is the plant actually from the bird's eye view. If you see from the top, some inside picture of the plants, some machineries, and maximum of them are from Europe, Canada, and other countries. A quality control lab. This plant has the capacity of producing 1.5 billion capsule and tablet actually per year. Honorable President also visited the plant last year.
I congratulate Square Pharmaceuticals Limited for what they are doing in Kenya. The products they are producing in Kenya and selling to the Kenyan market, the products they are producing from here and selling elsewhere, the jobs they are creating for us in Kenya, the manufacturing opportunity that they have made possible in Kenya, and the collaboration between private sector players in Bangladesh. And
so actually, Honorable President visited the plant and he was very much happy, and he encouraged us to continue the expansion of the plant, what we are planning to do so very soon with your support.
Private.
We also invited a number of doctors to see our manufacturing plant. Already a good number of doctors from Nairobi and as well as upcountry has visited our plant. We wanted you to see the quality we are making in Kenya. How good is it? So here we have Dr. Eric Zenga, the president of Kenya Association of Physicians. He has visited the plant along with some other doctors, and also psychiatrists and other group of doctors visited our plant. This is a team from MPSHA, including their chairman and vice chairman. Other group also visited the plant. We also invite you to come and see our plant. You will find the difference for Square producing in the country. You will have the confidence. Already we have a quite good number of products available from this plant in the market. Protas is our recent product already in the market. Angiloc Plus, you already know, already in the market. Deprex or Lanzapine in the market from this site. Another set of products here, we have Etoticoxib, what we are producing from the site already in the market. Trampa, our recently introduced product, paracetamol and tramadol from this plant, already in the market. Melcam is already in the market. 2 new products are also coming very soon. Montinel, Montelukast levocetirizine, and Seroprex, that is Quitipin. We are working much more new product. Now we will tell you what Square is coming with diabetic management. So as Dr. Paul Gogi has mentioned, many slides, many medicine what can be used for diabetes. We see the core defects in diabetes, especially the type 2, that is increased in hepatic glucose production, decreased insulin secretion, and insulin resistance. So to counter this, we have this brand called Glutamate, combination of sitagliptin and metformin. So this covers the 3 defects of diabetes. We have 5,500 and 50,000. That is twice daily, 1 tablet. And this combination is very good for HbA1c control compared to monotherapy. At the same time, it controls very effectively HbA1c compared to monotherapy, especially when the dose is high. That means 50 by 1000 will give you very better results. Is also very good for controlling fasting plasma glucose and postprandial plasma glucose. This therapy is better than monotherapy. When you give separately sitagliptin or metformin, combining the both is better and gives very better results. Now we have another very good combination, that is Glimpa, combination of empagliflozin and linagliptin. And it has very good effect. We say 2 proven diabetic medication and 3 ways of lowering blood glucose, and which is in 1 pill. That is the combination of empagliflozin and linagliptin. It is cardiac safe. It controls blood glucose. It is very good for the patients having liver and kidney disease, and only 1 tablet that has to be taken once in a day, and it is very much cost friendly for the patients. So that is Glimpa. We have 2 strengths, 10 by 5 and 25 by 5. Whether there is a possibility, can you prescribe Glimpa as well? There are some clinical studies which shows that this combination EMPA and Lina shows better glucose or HbA1c control reduction compared to the monotherapy or separate combination, separate of empagliflozin and linagliptin. The study is there. Ensure 2 times more success in achieving HbA1c goal compared to the monotherapies. There's another study. I'll not go to the details. Then we have linagliptin plain. The brand is called Linita, which is the safest DPP-4 inhibitor for the patients with cardiac, renal, and hepatic impairment. So when patients are coming with diabetes, having this issue, you kindly consider our Linita. And this Glimpa, Glutamate, and Linita, especially Glimpa and Linita, are available all big hospitals like Aga Khan, Nairobi Hospital, Avenue Hospital, MPSHA, AAR. So kindly show your support where you go and see any patients require this medicine. We also have, I will mention only other 2 products, that is bisoprolol. When the patients are coming with diabetes, they are also having hypertension. We are having the most affordable bisoprolol in the market, that is Bisolol 5. And it has a school line, so you can achieve 2.5 as well when that is required. And the last product I am going to mention, that is Telmiloc, most affordable Telmisartan, which is coming with CEP grade raw materials. We have both 40 and 80. So better glycemic control, at the same time manage your hypertension for the patients. And all this product, very soon we are shifting it to Kenya EPZ plant that will be locally manufactured with the similar technology what we are getting from Bangladesh, from our US FDA approved plant. And to inform you, Escort Pharmaceuticals Kenya EPZ plant has achieved the milestone of first export this year. We have exported to Somalia. So this is the revenue we are gaining, earning for Kenya. So if you love Kenya, support Escort Pharmaceuticals, who is quality medicine and serving to the patient at very affordable cost. Currently, actually from today, we are having East African Community Audit, which is going through. If it is, I believe we will be having this ESC GMP very soon, and we will be exporting to other countries, that including Tanzania, Uganda, and other African countries very soon. So your support is highly appreciated. Thank you so much. As a local company, we always appreciate. If you support us, we will grow, Kenya will grow, and people will get quality medicine at affordable cost. Thank you so much, Dr. Mary.
Thank you, Mr. Rinton, for that presentation. In the interest of time, I'll just take a few questions that are on the Q&A section for Dr. Ngugi. The first one is, does pioglitazone have any side effects on the bladder? The second question is, when can one shift from rapid-acting insulin to Mixtard? And the other one is, please, do we use insulin for management of type 1 diabetes or type 2? And at what point do we use it in type 2 diabetes? And then someone has asked if you could comment on the sudden hype of Ozempic and the weight loss phenomenon.
All right.
Over to you, Dr. Ngugi.
First one was The first question was what, Mary?
The first one was,
Mary,
does
the first question was?
pioglitazone have any side effects on the bladder?
That there is no, it's not confirmed. The next one was
the next
about
question was,
Ozempic.
when you shift
Well, from short acting to Mixtard, is
from
that so?
rapid? Yes,
To Mixtard.
yes.
I don't think the reason for change of that regimen, because the short acting you use it, the rapid you use it together with basal, that is, there should be the best regimen. Mixtard is a convenient regimen. And the only situation I would think it would be applicable would be patients who cannot manage the rapid and the basal and the bolus for reasons that are either social, cultural, or employment. They cannot be able to use insulin at lunchtime. They're having challenges of injection. Maybe they need somebody to inject them in the morning and in the evening. Please note that Mixtard has more risk of hypoglycemia than the other one. So it's not a preferred change, but sometimes patient circumstances may force you to do it. Next.
Do we use insulin for the management of type 1 diabetes or type 2 diabetes? At what point do we use it in type 2 diabetes?
Insulin is used exclusively for type 1 diabetes. For type 1 diabetes, you don't have an option of using anything else. However, and you must tell your patients that at one time they start with the tablets. At one time the tablets will fail and you have to use insulin. Insulin is also exclusively used to patients who are pregnant and are type 2 diabetics who have previously been on OHA. I've seen a question in the question board that asks whether you can use metformin and glibenclamide in pregnancy. I think there are some centers in the world that can and use, especially when, let me go backwards. For pregnancy, you want very tight control of sugars. You want fasting sugars to be below 5.4. And that perhaps is a challenge when you're using those tablets exclusively alone. So in my practice, I find it's easier to use metformin with insulin than using sulfonylurea with metformin. Glimepiride and glibenclamide has been used. There may be situations whereby somebody gets pregnancy after newly being diagnosed with diabetes, and their sugars are perfect with this low dose of glibenclamide and metformin. I do not see reason to change to anything if they are achieving the glycemic control.
All right. Yes, then the final question was on Ozempic and how it leads to weight loss.
I think the mode of action of Ozempic, like GLP-1, is mini. It starts from the brain. They act on the satiety center in the brain. They act on the stomach and the GIP, in the incretins, in the abdomen. But the whole thing starts from the brain up to the GIT. So the final result is that they make you have low appetite, anorexic initially. That's why we start small dose incrementally, because the nausea and the vomiting sometimes is too much, and the quality of life may be bad. And that's why you build up so that by the time the patient is on therapeutic dose, it's only that they're eating small portions. And please note that that's the same reason bariatric surgery uses. It increases the stomach capacity to have a lot of food. And the same thing, semaglutide influences the capacity for the stomach to want more food. in simple terms there.
All right, thank you. There are very many questions that have been asked, and hopefully some of them have been answered in the course of the presentation. But in the interest of time, I'd like to thank Dr. Paul Ngugi and Mr. Rinton Chakraborty for their wonderful presentations. I am not sure if there's anyone from our KME leadership on the call, but I think on behalf of Kenya Medical Association, we would like to thank you for the presentation today. And we look forward to further collaborations in the near future. So from our end, this is thank you for the webinar. For your CPD points, they shall be awarded to the doctor number that you had provided during registration. And this presentation, this discussion will be uploaded to the KME YouTube channel in the coming days. So from our end, it's Asante Sana, and we hope to engage with you all in the near future again. Thank you.
Thank you, Dr. Thank you so much, Dr. Paul Ngugi, Dr. Mary. We really appreciate for your excellent moderation, at the same time presentation from Dr. Paul Ngugi. Asante sana.
Karibu.